uh, pulmonary toxicities with immune therapy. This topic is actually an emerging topic in pulmonary, especially that we are seeing a lot of growth now happening in the management of cancers. And a lot of these medications are actually emerging daily. And if you have access to one of these platforms like Medscape or stuff like that, you will be surprised like almost every week FDA is approving a new agent for treatment of a new cancer. You're going to face it a lot in your practice. We've been seeing a lot during the, at least my last 2 years over here. It has been talked a lot about a lot in the oncology boards and in the grand rounds. So this is something very important that as a pulmonologist you need to be aware of. Now, immune therapy in malignancy, they are mainly now targeting two arms. One of them is using antibodies that are directed against the programmed PD-1 and programmed cell death legend 1, PD-1 and PD-L1. The other arm they are using now also is cytotoxic T lymphocytes that are targeted against B lymphocytes. That's used in the in treatment of malignancies, mainly hematologic malignancies, CLL, I think AML and non-Hodgkin's lymphoma are the targets that we are using for now. Before I talk about immune checkpoint inhibitors, the effect of immune suppression mainly that we are using in treatment of malignancy or other rheumatological diseases are actually can affect us as pulmonologists in two ways. The number one is that they can increase the risk of infection. That is going to be either way on top of your priorities, because you're going to see, despite how common it is that we see it, it's still very rare, and infections actually lie on top of the differential whenever you get a patient in such a case. And the other arm is actually inducing inflammation in the interstitium of the lung. So what are the immune check inhibitors? Immune check inhibitors are actually monoclonal antibodies, as I've mentioned for you before, that are directed against PD-1 and PD-L1. How do they work? Now, initially these were presented to the management of autoimmune diseases by inducing the immune system to act against, suppressing the immune system to act against its own antigens to treatment of autoimmune disease. As one of the by findings, when they use these medicines, they saw that it actually affects the immune system in two different ways. Sometimes it can act as a pro-immune, which is the case that we are using in the case of malignancies, where you make the immune system act against auto antigens, mainly the ones that are present in cancer cells. So it works on two different arms depending on what you are treating and the type of monoclonal antibody that you are using. You can either direct your therapy towards killing cells or actually suppressing immunity. Again, repetition of what I said, they heighten the immune activity against self-antigen, resulting in immune-related adverse event in a significant proportion of the patients. Actually, when you activate the immune system to act against self-antigens, it's not all the time that you are directing it towards the bad antigens that you're dealing with, the cancer antigens that you want to treat. Sometimes the immune system acts against self-antigens, and there has been a long discussion and a lot of description of side effects associated with the use of immune check inhibitors. So lungs is an organ that we are interested in, that actually we see result in inflammation in, but for the cancer doctors, it can affect everything from the skin, brain, pituitary. As you see, the list is long and it's growing. And actually there is consistently coming data in the NCNN about how to approach and treat each different organ. Now, we might be facing some of these when we are treating patients in the ICU with toxicities, but it is beyond the scope of this lecture. Maybe we can talk about it later or deal with it case by case if you find it. But here we're going to focus mainly on the lungs. So how do they work? As I mentioned, they are directed against PD-1 and PD-L1. And They are showing a great promise in the management of multiple malignancies. One of the things that we see is actually in non-small cell lung cancer carcinoma, the percentage went up from, I think it was 3% successful rate in treatment. Now we are heading towards 15 to 17% successful rate. Just for you to be familiar with the names, the PD-1 monoclonal antibodies, nivolumab, pembrolizumab, plimab, and dostarlimab. The PDL1s, these are their names, just for you to be familiar with them. These are the ones that are described at the current time. And as I mentioned, they are approved in various malignancies. The list is very long. I actually deleted it, but there's a lot of things that are covered: pancreatic cancers, renal cancers, blood malignancies, lung cancers. Everything is almost coming in to be treated with these immune check inhibitors. The other arm that is also with the immunological, let's call it this way, therapy of malignancies is the use of the CAR T cells, the chimeric antigen receptor T cells, as I mentioned for you before. They modify the T cells so that they will be targeting CD19 on the B cells, and they are used mainly in the treatment of hematologic malignancies, ALL, CLL, and non-Hodgkin's lymphoma. Now, for the CAR T cells, the way that they cause inflammation in the lung is totally different. It is a cytokine release syndrome, and they have described multiple cytokines involved. I have the list for you: IL-6, interferon gamma, TNF, IL-2, IL-8, and IL-10. Okay, they can start with capillary damage, capillary leak, renal impairment, liver impairment, and cardiopulmonary compromise in the sort of direct toxicity or inflammation. Just to familiarize ourselves a little bit beyond the lungs, usually when patients develop inflammation or what we call adverse effects secondary to these medications, they present with non-specific symptoms of fatigue. They might have infusion-related reactions. Very common is actually having hypotension. And do you know how they develop hypotension in patients who are receiving monoclonal antibody therapy? It's actually based about the fact that when they are in an acidic environment, they tend to do dimers, and these dimers act on the vasculature, inducing vasodilation. So the treatment, there's no known treatment. Some say slow the infusion, and sometimes even making the patient's blood more alkalic can break these dimers and actually result in resolution of their hypotension. We saw a case of that. That's why I know it's not because I'm the smartest one on the planet. Anyway, the very important is the cytokine release syndrome. As I said, this is mostly associated with the CAR T lymphocytes. It is an acute systemic inflammatory response, shows with fever, multiple organ failure. As I mentioned for you, it is with the CAR T cell therapy mostly seen. Other toxicities, just as I mentioned before, for you to understand how diverse the effect of the immune therapy can result on the systems. It can result in skin, GI, hepatotoxicity, endocrinopathies, infections. As you see, the list is very long. It can affect anything. As I mentioned for you, just like the guidelines are coming for each one by itself. It's a very broad topic. We're not going to cover it today. So what is pneumonitis caused by the immune checkpoint inhibitors? Is defined as focal or diffuse inflammation of the lung parenchyma. It's very important to understand that there is no specific pattern through which these pneumonitis they can show. No symptoms, no pathology, no radiographic features are actually specific for pneumonitis. They can present in various ways. I'm going to show you all these various ways now. The only thing that you need to know when you are suspecting this pneumonitis is that the incidence of the disease or the symptoms and the chronological sequence timing from the time that the medicine was started until the development of these changes that you're going to be seeing. Pneumonitis is usually, it is rare as a complication to happen. The risk of happening is only 5% when we talk about all immune therapy directed, whether it is the CAR T cells or the monoclonal antibodies. Out of the 5% is only 3% that is actually caused by the monoclonal antibodies, and the 2% is actually divided between combined therapies or the CAR T cells. Chronological pattern between the development of pneumonitis and initiation of therapy was actually studied on multiple studies, and there is a huge variation. On average, it happens between almost, I would say, 3 months after initiation of therapy. Sometimes it can present earlier, and sometimes it can present up to 1 year after initiating of therapy. And here you fall in a very huge dilemma with these patients, because most of these patients are not only on one agent for therapy, so you cannot differentiate whether it is caused actually by the immune check inhibitor, or if the patient received radiation therapy at the same time, if you are dealing with lung cancer, whether it is a recalled radiation pneumonitis. Sometimes even the combined chemotherapy that they use, they can result also in similar picture, and it can also present as pneumonitis. For this diagnosis, it's very important that it's a diagnosis of exclusion. You have to make sure that the patient does not have anything else, and on the top of the list that they have always insisted on is infection. As I mentioned for you, the overall incidence is 5%, 3% with the monoclonal antibodies, and the majority of the cases is actually seen when you have combined treatment rather than using a single agent, and the duration of treatment is usually within 2.8 months. It was earlier for patients who are receiving combined therapy, and still delayed adverse effect was described up to 1 year after exposure. Again, no characteristic or radiographic pathologies are specified for the immune check inhibitors. There is, up until now, there is no blood test that is diagnostic or aid in the diagnosis of the immune check inhibitors pneumonitis. They have talked a lot about what imaging studies that you are going to be using to diagnose these patients. They did a study, and actually I believe the number was almost 80% or around this high, it's here, 1/4 of the cases, 25%, that the regular chest x-ray will actually miss the diagnosis. So the preferred modality for diagnosis is actually CT scan, and not even CT scan. They even recommended to use the thin cut CT scan, the thin cut CT scan with almost 2 micrometers cut, so that you will be able to detect the early changes. Clinical symptoms, usually they are non-specific. They can be seen in a variety of diseases: dyspnea, cough, malaise, low-grade fever. Some patients may even be asymptomatic completely despite having a diffuse lung disease, and you might be hearing crackles whenever you are ausculting the lungs. The differential diagnosis is broad, starting with infections on top of the list, pulmonary hemorrhage, edema, induced pneumonitis, metastatic disease, heart failure, PE, veno-occlusive disease, or pulmonary hypertension. All of these are on the list, but the most important ones that, as you notice, is the one at the top. These are the most important confounding factor that you're going to be seeing when you are dealing with these patients. How to approach, what is the diagnostic workup that you need to go through? As I mentioned, you start with a CT scan. Pulse oximetry might show you evidence of hypoxemia. Now, there is no strict guidelines about how to approach it. There are some recommended, and they came out in CHEST 2020. I will include all of that for you. But whenever you have a grade 2 or higher, consider doing an infectious workup to rule out underlying infection, because this is the main thing that you're going to be seeing as a differential diagnosis for this patient. Also, it's very important because the treatment of checkpoint inhibitors induced pneumonitis is actually immune suppression. You're going to start with high doses of steroids. You can consider mycophenolate. You can consider cyclophosphamide. So these medicines, you're going to suppress the patient's immunity more. So ideally, you must make sure that the patient is not actually infected. Usually when we see these patients, they are hospitalized. Hospitalized meaning that they are at least grade 2 or higher. because usually grade 1 they are asymptomatic. It's a minor disease. We're gonna go through the classification now. So mostly they're gonna be they are gonna be seen and treated as outpatients. We're talking about doing the pulmonary function test for these patients. Data coming is very variable. There was no clear cut about the value of doing pulmonary function test, but there was an how do you say it, like not expected, like suggested benefit from doing pulmonary function test is that okay, I will go just sorry first we're gonna go through what you're gonna expect it to see. Ideally you're gonna see a restrictive pattern, you're gonna see a decrease in the diffusion capacity on the lung. Do they help in the diagnosis? They are kind of suggestive, but ideally other pathologies will present in the same pattern. Whatever they all gonna show you, like heart failure, infection, any interstitial lung process will present in a similar picture on the lung function test. So the use of it actually to reach a diagnosis is very questionable, and mostly it is not reliable. Majority they are talking about doing the pulmonary function test actually for follow-up purposes, to see if the patient is actually responding to therapy or not, in terms of improvement in their spirometry and the DLCO. Clear? Okay. Biopsy for diagnosis. There is no clear-cut answer whether to do biopsy or not. What they agreed on was actually is that you treat it on a case-by-case status. So if actually you believe that doing a biopsy, when you take into consideration the risks from doing the biopsy, is actually gonna aid in the diagnosis of the patient and direct your medical therapy, then you have to discuss it clearly in the multidisciplinary group with the patient, with the oncologist, and accordingly you will decide whether you're going to proceed with doing a biopsy or not. The histopathologic patterns that have been described with the with this pneumonitis actually is very broad. They started from cellular interstitial pneumonia was seen in 36% of the cases, organizing pneumonia in 27% of the cases, and diffuse alveolar damage in 9% of the cases. So technically doing a biopsy, if you got to sum them all together, how much are you going to end up having? Like 70% of the cases you're going to get a very common pattern that can actually fit on various differential diagnoses. So what is going to be your main aid here when you are thinking about doing whether to do a biopsy or not, if you are considering a different entity or not, or whether it is going to really help directing your medical therapy with the patient. One more thing that is very confounding with treating these patients is actually metastasis of the disease or lymphangitic spread of the disease. They also can look in the same, like they can overlap in the picture with the pneumonitis. So whether to do a biopsy or not, there is no clear answer for that. And as you see, 25% of the cases, there was no pathology identified on the histopathology slides. So it's case by case. You decide according to what's the situation of your patient, benefit versus risk, and accordingly you can proceed whether you're gonna do a biopsy or not. It is not on the first line. Doing a bronchoalveolar lavage was also variably approached through different entities. The majority of the cases they describe that you will have an inflammatory pattern with the predominant T lymphocytes on the BAL, 80% of the cases. Now, pneumonitis sometimes can present even actually as an acute eosinophilic pneumonia with an exact AEP picture. So you will have predominant eosinophilia on your BAL. But the thing is that they insisted on the BAL in two situations: whenever you have grade 3 or higher, or whenever you have a grade 2 that is not responding to medical therapy. Because at that point you have to rule out infectious causes. So the main goal of doing a BAL is actually to rule out an underlying infectious etiology before you suppress the patient's immunity more. The main way to diagnose immune inhibitors pneumonitis is actually the CT scans. A lot of questions were raised. When to do CT scan? CT scans, you do CT scan as early as possible whenever you are suspecting the diagnosis, especially if the patient falls on the time table for developing this complication after starting therapy. And as I told you before, you have to understand the fact if they are on single agent, usually it's around 3 months, 2.8 months, what they mentioned before. If he is on combined therapy, you have to have lower threshold to getting a CT scan because the incidence is higher and earlier. And keep it in your mind up until 1 year after initiating of the therapy. CT scan actually is not only helpful in diagnosis, but it also helps us in two different arms when we are treating these patients. The first arm is actually diagnostic. When you are looking for other causes for this new onset interstitial lung disease, rule out other abnormalities. The other arm is actually to follow on the progression and the response to the disease, to the treatment. So CT scans is your main helper here wherever you're going, and as you see over here, think of CT scans is the preferable with IV contrast. Here again, as I said, follow-up chest CT scan is useful to assess the changes of the DRP findings and the response to treatment. When to do CT scans, also it is a very open topic. It's just based on your clinical context and the progression of your patient. On the CT scan, you have to read it you have to address all the findings that you find at the CT scans, because the findings that you can see on these pneumonitis is very variable, as you can see from here. You have to figure out the distribution, the pattern of parenchymal abnormalities, ground glass opacification, airspace consolidation can be reticular opacities, centrilobular nodules, intralobular septal thickening, and even you can see in advanced cases, you can see honeycombing with traction bronchiectasis. So you have to be very precise in describing what you are seeing on your CT scan, so that you can, when you do the follow-up CT scans, you can see actually whether you're getting worse or you're getting better, and is there a response to the treatment or not. CT patterns that has been described, actually there was the acute pattern, which looks like a diffuse alveolar damage, interstitial pneumonia. There was I'm going to go through this one, a transient pattern, which is simply a pulmonary eosinophilia pattern with an AEP pattern that you can see on the CT scan. Subacutely, it can progress into OP or hypersensitivity pneumonitis, and on the chronic phase, it can even look like an NSIP. And you need to understand that the one medicine, there is no pattern that is pinpointed to a single agent. Any agent can present in any of these patterns. That is why we pushed on the previous CT scan that you need to do your job describing and classifying what CT scan findings that you are seeing in this patient, because these changes are going to guide your therapy when you move ahead from this therapy. You have to have high level of suspicion whenever you see these changes with the time pattern. Again,
when you say DAD, this is pathologic.
Yeah, an acute.
How can you tell from the CT that this is a DAD pattern? I mean, DAD is a pathologic correlate of ARDS, right?
Yes. Now, this pattern, we talked about it before, that you can even do a biopsy and this can be seen.
Right. I mean, this
or
is
you can
clinic
do
pathological entity.
clinic pathological entity, yes.
Right.
Yeah.
Okay.
But we established before, Dr. Zaid, before you coming, that biopsy was on almost 75% of the cases that you can have very common patterns, like IP, OP, and diffuse alveolar damage, that are really not going to be very helpful depending on the clinical case.
Overlap with the radiologic patterns. You know?
Yes, yes. So this is just a simple description of the CT scan findings. How do we describe the NSIP? Patchy areas of GGO, irregular reticular opacities, architectural distortion, traction bronchiectasis with or without areas of consolidation, bilateral, symmetric with lower lobe involvement. OP is mostly like a multifactorial patchy alveolar opacities. On the peribronchovascular area with a peripheral distribution, may show a reverse halo sign, hypersensitivity pneumonitis, poorly defined small centrilobular nodules with GGOs, large or lobular areas of decreased attenuation and vascularity, as Dr. Zaid did, extensive bilateral areas of GGO and dependent airspace consolidation in the exudative phase. Traction bronchiectasis and decreased lung volumes are seen in the fibrotic phase, advanced, and simply an eosinophilic pneumonia with non-segmental consolidations or GGO might be unilateral, bilateral, transient, and migratory. Spontaneous resolution within 4 weeks is very common. We're going to talk about the simple eosinophilic pneumonitis on the latest slide, because this is something that is going to be completely approached in a very different way. Again, just going through the radiological patterns that you might be seeing. Here is the organizing pneumonia. As you see, you have the patchy infiltrates that is mainly peripherally located. You might see air bronchograms, and actually there is like a very small one on the second one on the top. I don't know if you can see it. Usually subpleural in distribution. Another pattern, this is the diffuse GGO pattern. If you can see it, I don't know if the mouse is going to pop up over there. Yes, here it is. You can see here. Okay, here. Discrete focal areas of increased attenuation with preserved bronchoalveolar markings. Diffuse interstitial process. Here, if you can see, there is an extensive, it's very small, I can see it on the screen, I don't know if you see it over here, there are like extensive, here, peribronchovascular infiltration, okay, subpleural reticulations, if you can see it over here, possibly you can see even honeycombing and, traction bronchiectasis with the severe cases. This is how hypersensitivity pneumonitis looked like, centrilobular nodules, bronchiolitis like appearance and tree and bud micronodularity. This is NSIP pattern for sure, mixed nodular and other subtypes, and clinically, like morphologically, we'll say it does not fit into any other category. Diagnostic criteria, this was suggested by Camos et al. In 2017. Their criteria was the exposure to the causative drug, development of new pulmonary infiltrate, exclusion of other risk factors, and they proposed dechallenging provides improvement and rechallenging causes worsening. But as we move ahead, when we talk about grading, rechallenging is actually something that you cannot do, because especially if you have a grade 3 and grade 4, the latest recommendation is not even actually to reuse these medicines again, because there is an increased risk of mortality with rechallenging. CHEST proposed these criteria as the newly identified parenchymal opacities in CT scan. Usually it's bilateral, non-segmental in distribution, with a temporal association with the causative agent and exclusion of other likely causes. Now, what plays important role in the outcome of developing pneumonitis is actually the more acute the onset of the pneumonitis, the higher the morbidity and mortality. The severity of lung involvement, grades 3 and grade 4, are actually associated with an way much higher mortality in comparison to lower grades. The response to treatment, older age, underlying lung disease, smokers, other comorbidities, and the status of the underlying cancer itself can play a role in the outcome. The grading system, actually they classified it into 4 grades. Grade 1 is the least, which is we have an asymptomatic patients. You have less than 25% involvement of the lung parenchyma or confined to one lobe only. Usually this diagnosis is based clinically and on CT scan. The management for grade 1 is actually observational only. I'm going to go through the treatment in details. Grade 2, when you have a symptomatic patient involving more than one lobe of the lung or between 25 to 50% of the lung parenchyma. Grade 2 is where you have to treat these patients. Usually the treatment is number 1, you stop the offending agent, and number 2, you start them on immune suppressive therapy, the least one, which is actually steroids. We're going to go through the doses of steroids also later. Grade 3, where you have severe symptoms. At grade 3, patient requires hospitalization. This is mostly where we start dealing with these patients. involvement of more than 50% of the lung parenchyma. All lobes of the lung are involved. The 5 lobes are involved, and these patients need active treatment. Grade 4 when they present with a life-threatening condition. Usually at grade 4, the patient is so sick to the level that they require even ventilation, non-invasive or intubation and mechanical ventilation. The management for grade 1 is, as I told you, number 1, you stop the offending agent whenever you establish the diagnosis. Usually no treatment is warranted. You can just keep an eye on them and follow them clinically. They advise to repeat the CT scan within 3 to 4 weeks to see the progression of the disease, comparing with the initial CT scan that you got. Others suggested to follow up also using spirometry and DLCO to see if there is any improvement in the symptoms. Now with grade 1, if the patient is actually clinically improving, depending on your patient and the general condition, for sure you can consider to resume the treatment, the immune checkpoint inhibitor if the patient is showing radiographic and clinical improvement or even resolution of his symptoms. Now, if the patient on grade 1 does not show clinical or radiological improvement, then you need to escalate your therapy. And these patients, if you decide that you are going to hold therapy and just stop the offending agents and follow up, you need to follow them frequently. They suggested here clinically on weekly basis. And if the patient is clinically improving, you can repeat imaging within 3 to 4 weeks. You can for sure repeat the CT scan earlier if there is any deterioration. So it's patient by patient based. Grade 2 therapy, when we escalate the therapy a little bit more, number 1, as always, you stop the offending agent, you start them on prednisone, taper, okay, 1 to 2 milligrams per kg per day, and you taper it over 4 to 6 weeks. You start tapering when the patient is showing actually evidence of improvement, whether clinically or radiologically. You keep them on the high dose until you start to see clinical improvement, then you start tapering down the steroids. In grade 2, you consider doing a BAL to rule out any infectious causes, depending on the patient. Also, you consider starting the patient on antimicrobial therapy. All of this is patient dependent according to what you are seeing and what other variants that you are dealing with. You decide whether to do it or not. How do you check on these patients? These patients every 3 to 4 days, every 3 days, clinical assessment, pulse oximetry, repeating chest radiographs according to the progression of the patient's case. Failure of therapy, you should start seeing improvement within 2 to 3 days after you start the high dose of prednisone. Okay, if not, then you escalate your therapy to grade 3. Grade 3 is actually when you have the patients being very sick. This is where they are usually hospitalized at grade 3. Grade 3 and grade 4, you need to stop the offending agent and you don't re-challenge. Grade 2, some authorities say that if the patient is clinically improved and you have radiological evidence of improvement and the patient is actually de-escalating to grade 1 or less, you can consider re-challenging depending on your patient and your approach after you discuss with them. But if the patient is grade 3 or grade 4, at any point you cannot re-challenge them with the immune check inhibitor. Okay? On grade 3 and grade 4, you must rule out infectious diseases. Okay, BAL, a biopsy is considered, hospitalized, and you start antibiotics on grade 3 and grade 4. On the pharmacological management, you start empirical antibiotics. You start them on methylprednisolone, 1 to 2 milligrams per kg per day. If no improvement within 2 days after starting the therapy, you can use infliximab, you can use mycophenolate, you can use cyclophosphamide. And usually you taper the steroids over 4 to 6 weeks. Understand that the infliximab, the mycophenolate, and the cyclo are add-on therapy to the methylprednisolone. And there is one, sorry, it's not highlighted over here. You can even use IVIG for 5 days in these patients in grade 3 and grade 4. Okay?
The main problem is a lot of the time when we have grade 3 or grade 4 patients, guideline or they suggest to do bronchoscopy and BAL, most of the patients at that time are not candidate for procedure.
The hypoxia.
Yes.
Most of them.
Then ideally you should do it.
Yeah.
Ideally, if you cannot do it, for sure you're gonna treat them empirically until you make sure you try to get your answer in one way or different, and see if they improve or not. This is just a quick summary for you. You can look at it. If the patient, so grade 1 is asymptomatic with with radiological changes only. Grade 2, mild symptoms, not interfering with daily activities. Grade 3 is symptomatic patients, limited physical activities, requiring supplemental oxygen. This falls on grade 3, and grade 4 is a life-threatening, requiring invasive support. There's a grade 5. These patients, they show up dead because the lungs are already fried out completely with that. The investigation approach, as you all start with a CT scan, microbial assessment when necessary, infectious consults when necessary, pulmonary and infectious. This is from the NCCN actually, okay? And so consider pulmonary consultation and ID, bronchoscopy, to rule out alternative diagnosis. The management grade 1, you just hold the agent, monitor clinically, repeat radiologically as needed. You can re-challenge with the grade 1. Grade 2, you hold the agent, you start them on prednisone, and you monitor the symptoms. And if you see when they stretch to the follow-up, if improved to grade 1, consider resuming immune therapy. So you need to have evidence that in grade 2 that they are actually improving before you re-challenge them. Okay, if the symptoms are not completely resolved, consider discontinuing the immune therapy, and after symptom improve, taper steroids over 4 to 6 weeks. Grade 3 and 4, as mentioned, hospitalization, methylprednisolone, prophylactic antibiotic therapy, follow-up CT scans in 1 to 2 weeks. If you lack response, then within 48 hours, this is we consider the add-on agents, the infliximab, the doses are here, IVIG, MMF, or cyclo. Some considerations, some stuff to highlight when we're talking about that. Now, the first point, it's kind of confused. I hope that I got it in the right way. So for patients who are actually on immune suppression and they are treated with immune checkpoint inhibitors for non-pneumonitis causes, okay, these patients actually, the outcome in treatment or response to the immune check inhibitors was not impacted by them actually being on immune suppression. But for the patients who develop the checkpoint inhibitor toxicity, starting them in immune suppression actually reduced the efficacy of the immune therapy. You got it? Clear? Okay. If they have pneumonitis, if you immune suppress them, the response was to therapy. The immune therapy was less than the controls. But if they were treated on immune suppression for another reason other than pneumonitis, the outcome was not impacted. Okay? Why we put this over here? Because as we move ahead, also we're going to talk about this. When you're considering restarting these agents, you have to understand this fact, because reduced response, you have to weigh your benefit versus risk on these patients when you're going to make a decision whether to restart it or not. Relationship between immune therapy toxicity and efficacy, meaning that if the patient develops toxicity, does that mean that the drug is working better, so his chances of survival is higher, or it is actually damaging more, so survival is less? There is no clear data on this one. Some studies said that it actually reports better response to the therapy. Some said no. So there is no relationship. Any biomarkers that can be used? Up until now, there is none. They are studying interleukin 17 as a factor, and also eosinophilia as a factor, but up until now, there is nothing established to clarify with any blood test that you can do that will guide you to more to a drug related pneumonitis. Does improvement with glucocorticoid therapy confirm the diagnosis? It does not, because as we saw, the patterns are very diverse. They can be seen in multiple diseases that are actually the same treatment is used. It's high doses steroids. So whether it is the drug or it is something else, you cannot give a correlation just because the patient responded to to steroids. One entity was also some self-limited diseases that just recover by themselves without
Radiation
intervention.
pneumonitis, or if the patient took radiotherapy and at the same time
Exactly.
or later
Yeah.
on immunotherapy.
Yeah. When should you think about it? When suspect offending drug stopped in patient. Okay, when to stop the medicine? Stop it when you think about it. Okay, until you figure out what's going on with the patient. Okay. Now, does stopping if you stop the medicine and the patient is started to improve, this strongly supports your diagnosis. This is the only benefit that you get from that. But it's very important whenever you think about it, you just stop the offending agent. Now, what to think about when you are after like you treated and whether you're going to restart it or not? It's actually needs a multidisciplinary approach. It's not one by one. You cannot not one dress fits all. Depends on the malignancy that you are actually treating with this drug. How much the drug is actually working in treating that cancer. Okay. Whether stopping the medicine or not, how is that going to affect the patient and the outcome and the survival? Do we have another options to treat this patient other than the offending agent, or it is the only offending agent? So how to approach this? You need a multidisciplinary approach to the patient, between the pulmonologist, between the oncologist and the patient, to discuss the options and see what is going to be beneficial for the patient. So it's totally open, depending on the patient and depending on what malignancy you are treating and what are the management options that you have. Should you rechallenge? As I mentioned for you before, on grade 1 you can rechallenge, on you can think about it in grade 2 if they are showing clinical and radiological evidence of improving back to grade 1 or less. Grade 3 and 4 you don't challenge. They mentioned this over here, but this is something very specific. You can consider rechallenging depending on your patient and the malignancy you are dealing with, if this is the only treatment available. Otherwise, the patient is going to die. And I don't know how much this is correct, but I think it's just tailored patient to patient, depending on what you are dealing with, what is the life expectancy, and if it's the last shot and what would the patient decide at this point. You have to be clear and open whether they decide to proceed with it or not. There is an entity called the transient asymptomatic pulmonary opacities. Now, this entity was specifically described in patients who have non-small cell lung carcinoma that was treated with osimertinib. So in these patients, after starting the therapy, they were asymptomatic, but they showed pulmonary opacities, okay, that are following an acute eosinophilic pattern, okay? These patients, they were transient. They come and go by themselves without even stopping the offensive agent, without even starting any therapy. Okay? Now, in these patients, actually, they found that these patients, usually, their response to the treatment is higher than patients that they don't develop it. What do you see on CT scan? It's here. You can see it, right? They have the arrow on it, okay? And just you continue the therapy, you monitor them clinically, it completely resolved over here. And as I told you, this is associated with better outcome. They mentioned in these patients. But you have to bear in mind, okay, this needs to be followed clinically closely, because this simply can be a different case. It could not be the transient asymptomatic opacity. It could be immune check inhibitors induced pneumonitis, and the patient might actually get worse. Just an interesting one I wanted to share with you. I think that's it for me now. If anyone has any questions, I would be more than happy to answer.
Yeah. You may have mentioned about the COVID, complicating the diagnosis before I came, but COVID can give you exactly the same
Picture.
Yes, clinical and radiologic and even pathologic patterns, so something to keep in mind.
Actually, I did not mention it, but yeah, you're right. There was a paper even recently released about it.
And
Yeah.
on these patients.
Any questions?
Thank you.
Thank you.
When you said about the eosinophilic pattern about the very last CT,
Mm-hmm.
was it like the BAL or?
No, this is a radiologic pattern.
Radiologic pattern. No?
Yeah. It looks like an AEP.
Okay.